What is up? What is up, everybody? This is Dr. Andrew Kim, MD. I'm a board certified psychiatrist, and thank you for joining me on another episode of the Insomniacs Livestream on my YouTube channel. So, for those of you who are new, we do this live stream every Tuesday night and every Saturday night, 10:30 Central, 11:30 Eastern. So, thank you very much for joining. We try to talk about mental health related topics. Sometimes they are directly about some clinical topics in the field of mental health and psychiatry. Other times it's about pop culture related kind of things. Like last time we talked about tipping culture, relationships, etc. So today, on today's episode of the Insomniacs livestream, we are going to be talking about sexual side effects. So sexual side effects on SSRI medication or selective serotonin reuptake inhibitors. So what we're going to do is we're going to attempt to have a balanced conversation because I want to be a voice of reason in this very polarizing topic. I know that there are some people out there who probably downplay, the concept of the incidence rates and the degree of impact that sexual side effects can have from SSRIs. And there are those who are very anti-psychiatry, who are vehemently against the use of SSRIs at all. And there's a very big movement, about vilifying the use of SSRIs at all, which I understand what some of the criticisms are about, but also probably does an injustice to those who benefit from SSRIs. I think they have some valid points, but I also think that some of those voices have gone overboard, and I think the truth is in the middle. So hopefully today we can have a balanced, nuanced discussion about the realities of sexual side effects on SSRI medication, to review what those are, to review the high percentage rates at which they occur, the importance of trying to normalize having a very transparent conversation with whoever is prescribing this to you so that you feel like you're truly getting, actual, informed decision making capabilities by knowing what the risks are, so that you also are an advocate to speak up when you feel like you're experiencing some of these things. Some of the potential workarounds, which sadly do tend to only have mixed results if you're having sexual side effects on SSRIs. And also then we'll wrap up towards the end with this some people will already, get upset at me of using this word, the still kind of controversial topic of PSSD or post-SSRI sexual dysfunction. Now, I want to have a nuanced conversation about that because I actually don't think that it's very controversial to say that some people may have a prolonged recovery after stopping SSRIs to have some sexual side effects resolve, where some patients, it may take them months, if not even longer sometimes, to recover. I think what's controversial is really this concept of the frequency and incidence rate of permanent sexual dysfunction. And I'm going to be open minded and I want to have a discussion. So I think we want to have a balanced conversation because if you type that term online, you will be inundated with numerous websites, blogs, books, etc. And some of you may already be familiar with that concept, but let's talk about that, the best we can over the course of today's episode. So before we dive in, because we're going to be diving into some minutia today about side effects, please remember, I am not your physician. This is a YouTube channel. I'm doing this for educational and entertainment purposes for the sake of the listeners on this channel and subscribers. If you are looking for direct medical advice about your SSRIs, side effects, concerns, risk-benefit ratios of your medications for treating your condition, you need to talk to your personal physician, nurse practitioner, whoever, your family medicine doctor, whoever's prescribing your meds. This is not meant to be construed as direct medical advice. Just have to say it, just because of the nature of today's topic. Okay, so let's begin. So, couple facts. Let's just start with facts. The fact is, SSRIs, or selective serotonin reuptake inhibitors, which are used for various psychiatric issues. They're used for, they're FDA approved. Some of them are FDA approved to treat major depressive disorder, which is a subtype of clinical depression. They're used to treat things like generalized anxiety disorder, panic disorder. They're also used in OCD, PTSD. So they're kind of multi-purpose medications. Fact is, no controversy about this, in my opinion, SSRIs can cause sexual side effects. Fact. Another fact, from a percentage standpoint, SSRIs are probably, from a percentage standpoint, more consistent and more reliable at producing sexual side effects than they are actually likely to lead to full remission of clinical depression. That is a sad, sobering fact. So, again, no argument from me there. I do believe that the incidence rates and the consistency of people taking these meds actually experiencing some level of sexual dysfunction is actually going to be higher than the rates of remission. For example, although the rates and percentages are going to vary from source to source, which you read, I think from reliable, non-biased sources of information, if you look at some of the data of remission rates, let's say for clinical depression, someone taking an SSRI, remission rates are probably about 30% or 1/3 of people, maybe 30, 33%, to achieve full remission in the long run with SSRI medications like taking Prozac, Zoloft, Lexapro, etc. The incidence rate of experiencing some type of sexual dysfunction, which we'll describe in a few minutes, is more likely closer to 50%, in my opinion, 40 to 50%. Now, some, package inserts are going to cite very lower incidence rates of that. My only concern with those low incidence rates are those are oftentimes from clinical trial data sets that are, maybe a year long, rather short-term kind of clinical trials. So, when I think we combine that with decent, there's never really perfect naturalistic observational data in the real world because it's not a controlled setting. I mean, clinical trials aren't perfect in themselves, but I think when we try to combine the best we can, I would say incidence rates of sexual side effects are more like probably closer to 40, 50% of people, and that's a rough estimate, who take these meds. So I do think it's a fact that from a pure percentage standpoint, without trying to vilify SSRIs, I'm just saying fact, they're more consistent at producing sexual side effects than they are at actually successfully bringing depression to remission. Balanced fact, there are a percentage of people who do benefit from SSRIs, whether it's for treating their clinical depression, panic attacks and panic disorder, generalized anxiety. So we need to have that balance, right? Those two concepts can coexist, right? And that's what I meant by polarizing, right? When you go online, you're going to read forums and Reddit groups that are going to say these things are poison, they're the devil, they're the worst thing ever created by, in mankind. Others are going to say they're wonderful, they're life altering, they're changing. The truth's in the middle, guys, right? So can we have an adult conversation? That's the whole point of this live stream. Can we have an adult conversation to have a balanced, nuanced conversation about this topic? Fact, and this is the one that's going to piss off people. I should have learned my lesson after talking about Joe Rogan and Mel Gibson and stuff, getting hate mail and death threats. But fact, the concept of permanent sexual dysfunction. I'm not saying prolonged recovery. I'm being very specific here. Permanent PSSD after exposure to SSRIs, after stopping them and having permanent sexual dysfunction, is still somewhat of a controversial concept. Okay, did I say not possible? No, you didn't hear those words, but controversial. That warrants further investigation and study. There is a lot of information online basically just assuming and running away with the concept that this is fact and that the percentages are super high, and the 40, 50% of people that I cited who have sexual side effects while on SSRIs, they act as if all those folks are going to have permanent sexual dysfunction for the rest of their lives. And that's where the commentary comes in about this is poison, this is horrible, this is neurotoxic. But again, that remains controversial. And I'm talking about non-biased, reputable sources will tell you. They probably are scared to say this out loud because saying that just to have a neutral, nuanced, balanced discourse about that often gets met with stones being thrown at those individuals. Because even in the realm of research, discussions in the mental health world like this things have become so politicized, agenda driven, polarizing. People are now even afraid to have honest discourse with one another, to have these balanced conversations. It's horrible, but this is the reality we live in. Okay? So first, let's talk about what is just known and some of the risks of these sexual side effects while taking these SSRIs, and what you need to be equipped with as people in the public who might be taking these now, who might be considering taking these in the near future, who know someone who's on one of these right now. So before we dive into that, let's first, again, balance, right? Let's first acknowledge that many of the conditions that SSRIs are meant to treat, those conditions themselves can be causalities and factors of sexual dysfunction. Depression itself, clinical depression itself, can lead to decreased pleasure, decreased libido. It can lead to problems with performance, erectile dysfunction itself. Okay, anxiety can lead to these things. And people might shake their head and roll their eyes. Well, then I guess you have never had performance anxiety in the bedroom when being intimate with a partner. People might be embarrassed or ashamed to admit it, but trust me, at least one listener out there has probably experienced some degree of generalized anxiety, panic, performance anxiety in the bedroom that has led to sexual dysfunction and intimacy problems, whether it's premature ejaculation, erectile dysfunction, etc. Right? So psychological factors, stress, other medications besides SSRIs can lead to sexual dysfunction. There's even growing concerns now with things like Accutane and finasteride for, hair loss. And these things have now been having increasing concerns about sexual dysfunction as well. Alcohol. How prevalent is alcohol use and heavy drinking in America? I mean, part of what's kept my YouTube channel alive is just the relevance of alcohol problems in America. And millions of Americans have alcohol concerns, right? Alcohol is a known cause of issues with sexual functioning. Alcohol is known to cause erectile dysfunction. We don't really talk about that a lot, do we? Right? Minus jokes, right? Men especially say, "Oh, you got a case of whiskey dick," right? I mean, that's good. Pardon my French, right? But so they joke about it. I don't think they like talking about it. So we just have to recognize, right, other causalities, other contributing factors first. Are those things even happening at baseline before even starting on a medication treatment regimen with SSRI? So that's something that needs to be considered even before you have this conversation with your doctor, just so that you can kind of establish what is my baseline of sexual functioning before you even start on these prescriptions. But now let's talk about the sexual side effects that are known, right? So these are things that should be discussed with your prescriber, whether it's a family medicine doctor, psychiatrist, psych NP, family medicine NP, is that there is risk for sexual side effects, whether you're on a pure SSRI or these dual functioning meds called SNRIs, or serotonin norepinephrine reuptake inhibitors. Things like decreased libido, meaning just your drive or your interest level is just decreased in regards to sex drive, sexual interest. And some theorize that is that really almost an extension of kind of this emotional blunting phenomenon, right? So people do report it's not a very, again, well delineated concept, but I think patients know what we're talking about when we say, like, I just feel like, yeah, maybe I'm less depressed, less anxious, but I almost feel like my entire emotional spectrum is kind of blunted to some degree or flatter, right? So some even theorize that this decrease in libido or sex drive may be an extension of this more generalized kind of emotional blunting phenomenon that some people report on SSRIs, right? There are reports of, for men, erectile dysfunction, delayed ejaculation, okay? Genital anesthesia, so literally decreased sensitivity in the genital region for men and women, loss of lubrication in women, taking more stimulation and effort to achieve an orgasm, so either delay to orgasm or just total anorgasmia, meaning I can't even achieve an orgasm or climax anymore. Or maybe the degree of pleasure derived from an orgasm is less than before. So these are common known, sexual side effects of SSRI or variations of SSRI medications. Okay. And again, this part is not controversial. We know that these things can happen. I think these past 10 years versus maybe the previous decade, I think we appreciate that the incidence rates are higher than what was probably portrayed in the past. That was probably cited in training, as physicians were being trained in the past. And that's why we do need to stay open-minded, right? That there is an evolution in the knowledge base as we continue to have more and more data with these meds compile over the years, right? So it is crucial that whether if you're a clinician who's listening to this versus a patient who's listening to this, either way, for both parties, it's important to have a very blunt, transparent, non-judgmental, normalizing conversation when you're discussing risks and benefits of whether you want to be on one of these medications or be prescribed one of these medications, right? So to have true informed consent, you want to have a discussion about these things, right? And so, like, for example, right, to give you an anecdote, when I discuss this with, let's say, one of my patients who is treatment naive, I'm just very direct. I know it sounds odd, but as a psychiatrist, me talking about erectile dysfunction, libido and sex drive, orgasms to both men and women, this is an everyday conversation. This is an everyday thing. Those words literally come out of my mouth on a daily basis, as strange as that sounds, because it's necessary, right? And if your providers aren't talking to you about these things, you should bring it up and say, hey, well, what about those risks I heard about some sexual side effects with SSRIs? What's up, Ray? Ray's a regular listener here. Ray is asking, what is the physical, medical, biological cause related to erectile dysfunction from ingesting SSRIs and SNRIs? Yeah, we'll get into that. There's theories, and we'll try to cite some of those theories in just a little bit. So stay tuned I'll probably get to that in just a couple minutes here. But it's important to do this because if you don't do this, right, and if you don't have this blunt conversation, this just leads to confusion. This leads to more anxiety. This leads to patients struggling with this in secret and feeling embarrassed because, look, even in the year 2025, talking about, like, look at these words, right? I bet you there's some listeners out there over the last 10 minutes that we've been on the air felt a little uncomfortable by some of the buzzwords that I just said, right? Erection, orgasm. It's just something we have to get comfortable with. And trust me, you know people, you can probably attest to it, whether it's you yourself or others around you. If you said those words out loud, right, it almost causes a weird awkwardness sometimes, right? Some people are very comfortable talking about this topic, others not so much. So we can't assume that even clinicians sometimes feel comfortable. They'll do beat around the bush vague things, right? They'll say, any issues with intimacy? I literally just say, hey, we need to talk about orgasms, erections, your sex drive, delayed ejaculation, premature ejaculation. Again, maybe you could soften the words depending on the person and taking in cultural considerations with your patient, but you got to be direct. You don't want to be vague during this portion of the conversation. And this is an everyday conversation that I have. And even as you kind of go along in treatment, right, you have to weigh that risk-benefit ratio. Are you getting a robust response? Is the patient achieving remission? Are they at least having significant reductions in severity and persistence of their symptoms? And are they having any of these sexual side effects? And again, people are going to argue with me on the percentages, and I don't blame them. The percentages are all over the place, depending on what you read and depending on someone's bias, right? Statisticians, give me a break, okay? Statisticians and people who publish studies, there's always inherent human bias, right? So some studies are going to say 60%, 70% have sexual side effects. Others are going to say as low as 10%, which is probably inaccurate. But the truth's in the middle, but meaning probably half the patients who take these, luckily, are going to be very fortunate, are not going to get any of these sexual side effects. And in 13, 14 years of practice, I have witnessed that. I have a cohort of patients who, no matter how often I ask them about all the things we listed before, say, no, why do you keep asking me? It's weird. Like, you're almost weirding me out. You keep asking about my sex life and all these things. Like, what's your problem? What's your deal? And I'm just like, look, the percentage incidence rate and the prevalence of these is so high. It's my duty and responsibility to at least, at the very least, within the first year of treatment, I ask it a lot. And, if you are in the fortunate half who probably don't get this, then yeah, of course, then I'm not going to keep bringing it up like a weirdo after a certain point in time. But if you are someone in that 50%, give or take, who do get these, I'm going to be probably asking you until, you know, uh, I turn blue in the face, because I know that us effing with your intimacy and sex life, that is a part of your health, right? Intimacy, sexuality is part of your holistic well-being, right? We think about your emotional health, mental health, physical health. But look, we can't be taboo about this. Sex and intimacy, just as general concept, doesn't mean you have to be constantly having physical sex, but just sexuality, right, is a part of your well-being, right? So for me to ignore that would just be kind of putting stigma and taboo on a facet or domain of your health. So that is something that needs to be brought up and tracked over the course of time, right? So, I know we're getting a little ahead of ourselves, but let's talk a little bit about causes, right? What are, because this will relate to the PSSD portion, so we might as well talk about this. So Ray, if you're still there, so what are the potential theories of how some of these SSRIs might cause, some of these sexual side effects that I listed, right? Again, these are theories. There is some belief that indirectly some of these SSRIs may actually alter dopamine levels in certain areas of the brain. Again, loose theory. I'm oversimplifying, but for the sake of time, that's one of the theories. Another theory is that serotonin modulation can actually alter the HPA, or the hypothalamus pituitary, the HPA axis of the brain, and can indirectly affect even levels of things like testosterone ratios. There is a theory that this can indirectly decrease nitric oxide synthesis, which is going to be involved in blood flow and things like erections. Okay. There's theory that specific serotonin pathways and serotonin receptors may affect sex drive. For example, persistent downregulation of the 5-HT. 5-HT just stands for serotonin. So when someone says 5-HT receptor, there are numerous subtypes of serotonin receptors. So there's some theory that downregulation of 5-HT1A, or almost an imbalance of promoting 5-HT2A a little too much in certain areas. So alterations of these receptor sensitivities or receptor representations, that's a theory of how sex drive is affected. Okay. So those are all theories, but those are some theories of how, while taking SSRIs, they believe it can affect both the psychological and physical, meaning erectile dysfunction, orgasms, the abstract sense of sex drive. Okay. So again, to summarize, because I've seen some people popping in the last few minutes, right? No controversy, at least from my point of view. It's a well-known fact. SSRIs can cause sexual side effects while you're on them. And I just rattled off a bunch, right? And again, the emphasis has to be to really feel like you, as someone who might be taking one of these, is making an informed decision. You have to have conversations with the prescriber about these, and just have a very blunt, open conversation about the risks and benefits and the risk-benefit ratio of if these are helping you or not. Again, if I wanted to just get a bunch of clicks and have clickbait, honestly, and milk this and make money, I could just go on and on and on, just vilifying and really just joining the anti-psychiatry movement. It's a very populist thing, and there's money to be made there. Okay. I guarantee you, like, if I just converted my channel to anti-psychiatry and just bashed it up and down nonstop, which is actually easy to do. I have a lot of criticisms of my own field, so don't get me wrong. And you've heard me criticize my own field. I even think the way we diagnose depression is kind of stupid. I think how often we prescribe SSRIs is stupid. I think we're over-medicating America with psychiatric medications. You heard my stance on ADHD and ADD, right? I mean, I think a lot of things we do are stupid, but that doesn't mean that SSRIs don't help at least a portion or a cohort of people. And here's what I mean, right? I used to work as a principal investigator in clinical research. What I don't disagree with anti-psychiatry critics is many anti-psychiatrists, so meaning even like psychiatrists right now who are part of this anti-psychiatry movement, right? They say we're overprescribing SSRIs. I don't disagree. They say that the use of SSRIs in clinical depression is a joke and that it's no better than placebo. I will slightly disagree. I think when it comes to mild, and this is arbitrary, right? What's mild, moderate, severe, but what at least the research field defines as mild to moderate depression, I actually don't disagree with that sentiment. I actually think that SSRIs, I don't know that they're that much better than placebo in mild to moderate depression. But for those who understand statistics, like I actually don't think there's a huge argument that for severe, again, somewhat arbitrary, but severe cases of what we call major depressive disorder, which again is a paradigm that's, you could tear that apart easily, but let's just buy in, right, to this concept of severe MDD or major depressive disorder. No, the stats are actually pretty decent these are better than placebo for severe, right? So that's where I'll put a little asterisk and I will divert from some of the anti-psychiatry psychiatrists. I think that for severe cases of MDD, I probably wouldn't feel the same. But for mild, moderate, sure, absolutely, right? I don't disagree with the anti-psychiatry psychiatrists about the fact that these meds cause all these things. You just heard me rattle them off. It's just fact, in my opinion. I don't disagree that there's probably been a downplay of the incidence rates and prevalence. You just heard me say that myself. Where I'm going to hit the brakes a little bit is the next portion, right? The concept of PSSD, post-SSRI sexual dysfunction. But I want to have a nuanced conversation about that. So let's first describe that, right? So what are we talking about for those who aren't as familiar? What is PSSD? So in general, the easiest way to put this is it is this concept that after exposure to SSRI medications, your Prozac, your Zoloft, your Lexapros, right? That one can have either a very prolonged course of still having sexual side effects after discontinuation of the SSRIs, or even permanent dysfunction that never recovers, okay? Because right now, the general consensus, right, the general way we practice in the field of psychiatry is the concept of, hey, like, for whatever reason, when you want to get off these SSRIs and when we get you off of them, we expect that pretty soon after you stop them, with one exception, with fluoxetine or Prozac, because that has a very long half-life. It takes a long time for that to exit your body. But we expect that in general, that shortly after, or at least weeks after stopping these, that the sexual dysfunction should reverse and dissipate and disappear, and that it should get back to wherever you were at pre-medication. And again, keywords, I didn't say 100%, I said pre-medication, meaning, but go back to the beginning of this conversation, right? Where were you at before you even started them? Because again, some people take for granted that they were already having some sexual dysfunction, right? For various reasons. But the idea would be, we'd hope it get back and normalize to some degree to kind of where you were at pre and post, right? Pre-exposure. But there obviously has been a growing concern about folks who are either saying one of two things, that there is a very prolonged recovery course. And again, there isn't a universally globally accepted definition as of yet. But a lot of people kind of use a definition of, 3 months after the cessation or stopping of an SSRI, that sexual side effects and dysfunction still persist, that is what then, from a time length standpoint, constitutes a case of PSSD, right? Again, others are saying that they're having permanent sexual dysfunction with no recovery. Now, prolonged recovery, I mean, look, conceptually, I could see that, right? Because look, I don't think even with all the sexual side effects we just listed, right? We don't fully understand it. And to Ray, if he's still listening, you heard how I phrased it. These are all theories. We don't know the exact pathophysiology or cause and effect, like many things in the field of psychiatry, right? So, yeah, it's also hard to then understand the reversal, right? So that's why, in my mind, I say I'm just going to keep an open mind. Why wouldn't it be if we know that these can cause insults, right, and actually cause a problem? I don't think it's a reach to be like some people might have a longer recovery course, right? Who knows, right? Genetics, brain sensitivity, readaptation, reacclimation for your body to adjust. All these things are highly theoretical. We don't know, but all those variables, is one person going to recover within days and weeks? Yes, I've seen that happen. Versus someone else taking weeks to months? Yes, I've seen that happen as well. I've seen both ends of the spectrum. People who recover literally days after the meds exit their bloodstream that quickly. And I've seen people where it's taken months with an S for them to say, hey, you know what, Dr. Kim, finally, it's gotten back to the point where I do feel like those sexual side effects are gone. And they were kind of relieved, saying, I read all these things online, but luckily I feel like it's back to where it was. Maybe did take 2, 3, 4 months for that to occur. So that part, if we're defining PSSD with a cutoff of months to recover after stopping an SSRI, even though you're saying, most of these meds only take, a week or two for these to exit your bloodstream. Yeah, I could definitely, because I've seen it myself. I mean, I've seen it happen with my patients. So I do believe there is a cohort of patients who are going to have a more prolonged recovery to have intimacy in their sex life bounce back to where it was pre-medication exposure to these SSRIs. Okay, why? I don't know the exact why. Okay. But here's the thing, right? Some people are defining PSSD automatically in their minds as like permanent dysfunction. And that's where I still put that asterisk. And this is where I'm going to piss people off. And I've pissed plenty of people off, saying, I didn't say it's not possible. I'm just saying it's a little bit controversial. I still think the jury is out on the concept of permanent dysfunction from exposure to SSRIs, right? So some people say that after years of exposure with SSRIs, they have permanent PSSD. Others will say after like 1 or 2 doses, just limited exposure, they have permanent dysfunction. So let's just talk about the evolution of this concept, right? I mean, one of the physicians who made this kind of come to light more mainstream was a Dr. Healy, Healy. I believe, I could be wrong, so don't quote me. I believe from Scotland, UK. Then I believe had a tenure at one point somewhere in Canada, or was supposed to at an academic institution there. So look, most people, when they look up PSSD online, they're quoting studies, commentaries, interviews, the 20 some odd books from Dr. Healy, right? Who's kind of brought this topic front and center in the past 10 years, past 5 years, etc. So no, I'm, very familiar with that literature. But it's funny because when I hear people kind of quoting Dr. Healy, he gets portrayed as this like hero, right? That he shed this light on how evil, the field of psychiatry is. Right? But if you really read some of his stuff, it's very nuanced, right? So I'm not even necessarily just like anti Dr. Healy. He says a lot of things. He's like some of his core platform principles are probably been a downplay of the actual prevalence and incidence of sexual side effects. You heard me. I don't disagree. A big concept of his platform is the pharma industry. And, the pharma industry has done a wonderful job of suppressing negative clinical trials or concerning data to some degree, and really highlighting more of the positive findings, making those publicly known versus the negative outcomes. I don't disagree. I mean, a perfect example is there was a recently FDA approved medication. One of my colleagues was asking about it today. Oh God, what was it called here? it's fascinating. Let me look this. I don't want to misquote this. Yeah, I don't even know how to pronounce it because I never prescribe it. Gepirone, Gepirone. It's FDA approved for major depressive disorder. But what struck me when my colleague asked me about that was, I said, wait, that, I'm like, I'm somewhat familiar with it because I know that it tried to get FDA approved like at least 3 prior times and it never got approved, like in the last 3 attempts to get FDA approved in the last like 2 decades, essentially. How did it get FDA approved suddenly? Um, and again, I have to dig a little deeper, but what I can tell you is like, that's an example of kind of what like Dr. Healy's talking about, right? Is that, uh, that I know that compound, concerningly, probably 3/4 of the prior trials really have negative outcomes, showing that it really didn't have a remarkable robust signal compared to the placebo group. And so I would like to understand how suddenly on its 4th attempt to get FDA approved, now it's suddenly you know is an approved treatment, right? So that would be an example, right? So again, I'm trying to have a balanced conversation here that you know there are things that are valid and have merit, even for those who are very kind of anti-SSRI. But where it concerns me a little bit is, right, the assumption, right, the assumption that there is a known cause and effect of like permanent, keywords, permanent dysfunction from exposure to SSRIs to permanent sexual dysfunction, and that somehow the incidence rate of that permanent dysfunction is astronomically high. And that's where I will draw a line, and I don't care, whatever. A lot of people don't like me. That I'm just going to say the jury's out on that. I think people have to slow the roll, and people who just run wild with that and say, "Oh, it's like 70." You trust me. Go online right now. You're going to find physicians who will go on the record and go on their YouTube channels, and they'll write these. They're not well-written studies. BS, okay? Like their own editorial pieces ranting about how the incidence rates of permanent, keywords, permanent PSSD after limited exposure to SSRIs is like 75%, 80%. Like, I mean, these wild, bold claims without evidence of that whatsoever. Okay, they take surveys, they collect databases of self-reports of people, and then they just make the assumption that this is why. And then everyone always goes, okay, well, the European Medical Association has recognized PSSD. But again, like European Medical Association recently did recognize that in the last few years. But again, recognizing it more so for the case of prolonged recovery, or saying that, there's rampant permanent dysfunction that's happening, right? And I'm familiar with some of the studies, right? There are studies and websites and blogs. Again, they'll make bold statements, and either they put no fine print or they put the fine print and make it hard for you to analyze what they're actually saying. There's tons of articles about we have evidence of permanent neurotoxicity, that even limited exposure causes permanent neurotoxicity. And they love using that word, neurotoxicity. You know what they're quoting? A very limited study in rat models, where early exposure to SSRIs did seem to lead to evidence of some kind of permanent dysfunction with sexuality in rat models. And even from non-biased, analyses of that evidence, most non-biased sources will say that's pretty weak evidence. Okay, and that's if that's all you got, that's still not considered cause and effect, right? I know they often cite the Tel Aviv study, where they cite this very large study that was done from a database in Israel, saying, look, here's a large scale study. But then look, if you read, nobody usually cares. You just read the headline. But if the lay public actually went in and you read the actual study, it's doing a chart review of men who started on SSRIs, looking at just a national database at several hospital systems, who then started taking erectile dysfunction meds like sildenafil, like Viagra or generic, Cialis, and then kind of tracking their charts, showing that, after they stop their SSRI prescriptions, they keep taking the erectile dysfunction meds, and drawing a conclusion of, hey, is there evidence of permanent sexual dysfunction. I mean, that's a very, I'll say it's innovative, it's creative way to try to look at it from outside the box. But, you know, again, is it a super well controlled study about all these different comorbidities, causality, et cetera? No, it's just an interesting observation that there were a portion of men who, after starting SSRIs, who were not on like Viagra, Cialis, ED meds before, were still taking them after they even stopped their SSRI prescription after a certain point. So again, interesting observation. Causality, pathophysiology, cause and effect. No. And if you say, if that's your main bullet, look at that. I say, okay, cool. That there's something there, maybe, and we need to look at it more, right? So again, and then the vast majority of the rest are case reports, case studies. And look, am I trying to invalidate somebody's experience? No. But someone's experience in case reports and case studies, even if we're aggregating them, doesn't equal fact and reality. Because look, I have anecdotes. 13, 14 years, I've treated thousands of patients. How many patients of mine were convinced they had ADD? How many patients of mine came in their first sentence, I have bipolar disorder? Ends up, the vast majority don't have bipolar disorder. How many patients of mine come in saying, oh, I have this very specific subtype of OCD. I have relationship OCD. And then I find out they're anxious and they have insecurities and anxiety about relationships. It's called being a human. How many folks have I treated where the sexual dysfunction was related to anxiety, depression itself? How many folks have, oops, my bad. How many folks have had issues with misattribution, like, and not coming from a bad place. I'm just saying they want an explanation for their problems. They need to have something that make all the puzzle pieces fit. So again, it's just, what I'm saying is, if we solely just go off opinionated attribution of cause and effect, then okay, well then a lot of things are true, not just PSSD, right? So we just have to be careful, is what I'm saying. It warrants more studies. We do. Ray says, with such widespread use of SNRIs and SSRIs since the 90s, well, yeah, SNRI since the 90s, shouldn't we have a large amount of data by now on their side? Yeah, we do have a lot of data. Because here's the thing, right? Ray, we got to have a balanced conversation. I'm not saying that some people don't have prolonged recovery. I'm not saying it's impossible that there are cases out there maybe that don't have recovery. Because again, why should I stop my logic, right? I said, if I know that patients can get dysfunction while on them, why can't a cohort of people have some prolonged recovery versus the faster recovery we typically see? And then who's to then say there are some people, maybe there is some kind of permanent dysfunction? Again, I'm not saying it's impossible. What I have more of a concern with is physicians and psychiatrists who are riding the anti-psychiatry movement wave for profit and for prestige and not using critical thinking, right? And again, I don't even want to get into these stupid debates with some of these people. I really could care less what they think, honestly. But some of these folks out there are going to say, you know, SSRIs are poison. Oh, these people are lying to you. Someone like Dr. Kim is just a puppet of pharma, and they're all bought by pharma, brainwashed, and permanent sexual dysfunction is 70, 80, 90%. It's just underreported. Put it this way, Ray, okay? And this is why I keep saying the phrase, the truth is in the middle somewhere probably, is knowing that right now, I'm off a little bit probably, but let's just use rudimentary logic here, okay? And I know that it's not really a way to do it, but one, this is astounding. This is my commentary about the over-medication of America, right? So you can hear my viewpoint. I have a problem with how freely we're prescribing SSRIs and psych meds in general, right? There's a balance there too, right? So don't get me wrong. It's like there's problems with lack of access, especially to those most in need with socioeconomic, limitations, right? Like the most in need often have the least access. Yet for other folks, we're overprescribing, right? Um, here's the reality. Like one right now, meaning point prevalence right now, 1 in 18 Americans is taking an SSRI. If you want to be more conservative, 1 out of 20. So do the math, right? 300 something million people divided by 20. Or let's be real, like forget the kids and children. So let's put that in half, right? Say like the adults. So let's say 180 million people. Divide that by 20. Millions of adults are on an SSRI or SNRI right now, right? Now that's point prevalence. Now imagine since the basically every antidepressant minus the newer drugs like ketamine, esketamine, some of the things we talked about in previous episodes, but pretty much for the last century, right? It's not even just about the 80s onward, right? That's the fallacy. Even things that are pre-1980s, the 1970s antidepressants, the 1960s antidepressants, meaning tricyclic antidepressants, MAOIs, those are all variations of SSRIs, SNRIs, or some combination, right? Some variation. So we have had literally 70 years, so 70 consecutive years of exposure in America to variations of SSRIs and SNRIs. Obviously, that has ballooned from the 1980s to present. But even then, right, let's say 40 some odd years, 45 years of ballooned exposure of millions upon millions of Americans. And if some of these folks out there, right, some of these psychiatrists are saying the vast majority of almost every person has this like permanent, rampant, poisoned, permanent dysfunction. If we made hundreds of millions of Americans permanently impotent, there would be riots in the street. The field of psychiatry would have been shut down by now. I understand that pharma is a powerhouse, but don't get me wrong. The medical malpractice industry is like a 12, 13, 14 billion dollar industry and is only growing. Trust me, when they would have an absolute field day in America where we're sue happy and lawsuit happy if the rates of permanent sexual dysfunction were even remotely close to what some of these folks are saying out there. Field day. Okay. So, what boggles my mind is let's again, and I know people always criticize me saying, well, there's no funding to study. Give me a break. Let's study this damn thing, right? So I'm being open-minded. I'm saying, let's study it. Let's run. And how? I don't know how, because that's the challenge, right? So much goes into sexuality, right? It's multifactorial, because I think everyone can appreciate, right? There's a psychological component to sex drive and interest and excitement and arousal. There's physical components for women, lubrication, for men, with the strength of their erection, all these different things, right? So there is so much that goes into it that even like measuring baseline, what is 100% optimal sex drive? That's hard to define. Then controlling for all these different variables, hard to do. What is going to be the best measurement of optimum sexuality? Most of the time, they're measured by self-report. Like for men, what are you going to do? I mean, like there are a few ways. There are things called like, oh gosh, what is it? Like there's like nocturnal penile tumescence tests. They've literally put these rings on your penis and measure how many and like the strength of your erections at nighttime. Pretty cumbersome. I don't know how many people would volunteer to have that measured. Okay. They even have these like intrapenile cavernous sinus injections. Literally, they inject stuff into your veins to see what is the degree, just going direct to the source. Like, what is the degree? Do you have a flow problem? and measure the strength of your erection. So, I mean, these are just like super like cumbersome, invasive tests. Like, how would one even study this, right? For men, for women. I mean, it's just a cumbersome thing, right? So I don't even know if we're going to really get like 100% clarity, like even if one were to study. But here's the thing, right? I mean, so the logistics aside of like practicality of like being able to measure these things, which is the best way to measure them, how do we run this, like, but funding, people always use the funding excuse, right? Like, pharma's going to suppress this, pharma doesn't want to do that, blah 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 blah, right? Look, then screw pharma. Then let's get the medical malpractice industry to fund it. Let's get the handful of the highest performing law firms, and if they really think, talking with clinical experts out there, that this, and to academia, right? And trust me, there's hungry academics who want to become famous. They'll publish anything, right? So with all these folks, let's aggregate some money and funding. Let's run a study. Let's run a study and see what happens. Like, I mean, I would like to get some clarity as well. So let's do it, right? But then nobody wants to do it, right? So we just want it, like, everyone wants it both ways, right? I mean, so all I'm saying is we need more research. So let's do it. Let's research this damn thing. Let's learn about it as a field. Let's become more educated as prescribers, so that we could be better advocates and, better, give our patients a better informed consent, essentially. Okay. So again, I'm trying to be open-minded here, but it's just, we got to have these adult conversations and balanced conversations about this topic. It's when you bring up this topic, you have one party who's saying, ugh, or just scared to speak up, or scared to even raise curiosity. Then you got this other group saying, oh, it's a known fact. Like, most patients have this, they're just not saying anything. Or they're citing random stats, all these high things, but they don't want to do just more comprehensive studies. Because it is a hard thing. It is a hard thing to study. Let's acknowledge it is a tough thing to study for all the random rants that I just gave you a few minutes ago. We got to study it at some point, right? I put a link in the info to the Carlat report. Okay. I'm not saying they're the end all be all, but I really like the Carlat report from, it's a psychiatric publication. And I'm going to say they're very anti-pharma industry. Very anti-pharma industry. And yeah, they're not the end all be all. They also have very strong opinions, and I don't necessarily agree with everything they say. But when I want to make sure that I'm here, I want to always have a balanced opinion. I want to read their stuff because they really do have kind of this like anti-BS, anti-pharma kind of slant. Go read there. It's a very easy read. It's like literally a 3-4 minute read. So it's easy for you to get through. Even you don't need to have a science background. They have a very good, just high level bird's eye view summary on this topic of PSSD. And even their stance right now is the jury's still out. And I'm sure, even though they're well known to kind of be a anti kind of pharma, seen as a reputable source of information and sifting through data to give you very concise, easy to read clinical pearls, I'm sure they got some flack for saying that the jury's still out and there's more studying that needs to be done. I have a very similar viewpoint, and I do respect their opinion. They're willing to talk about the topic and say they're not sure, because it's okay to say you're not sure. And I think right now that is the best balanced method. It's like, let's be open-minded. Let's empathize and validate our patients' concerns if they're having delayed recovery. Let's try to support them the best we can, but let's also not fearmonger without knowing for sure if this concept of like permanent dysfunction truly exists or not, right? So let's end with just kind of the topic of, well, what can one do sometimes to try to mitigate or reverse these sexual side effect concerns, whether while you're on the SSRIs and having these side effects versus this realm of prolonged recovery, from SSRIs. Okay. I want to start by saying the evidence is quite mixed. So let's first start off probably with the easier conversation, right? If you're on SSRIs or SNRIs or some variation and you're having these sexual side effects, really the best course of action is to address the root cause, meaning if you can afford to and you don't feel like it's going to jeopardize your mental health and whatever condition you're treating, right? Is there ability to lower the dose and have that conversation with your prescriber? Because we do believe that sexual side effects, incidence rates are dose dependent. Higher the dose, higher the risk, it seems like, while you're taking these things. So, is there an opportunity where you could lower the dose and get away with the least effective amount possible to maybe then decrease the risk of these sexual side effects? If that's not good enough, then is there a possibility to switch to a different agent? And again, it's beyond the purview to go through every iteration, but like if we isolated this conversation to like depression, let's say, right? Is there an opportunity to switch to different atypical antidepressants, meaning non-classic SSRI, SNRI based medications? Like, could you do like Wellbutrin or bupropion, which really is more primarily a norepinephrine, very mildly a dopamine, modulating kind of med? It's almost more akin to like a mild stimulant, has far lower rates of sexual side effects. Is there an opportunity to switch to that? Is there an opportunity to switch to like an atypical antidepressant like mirtazapine that have lower rates of sexual side effects? So that's a conversation to be had. If those, let's say you're not in that domain, you're in the domain of I am getting benefits and robust benefits, yet I'm having these sexual side effects. So I'm kind of torn and I'm worried about the risk of regression and symptoms recurring if I were to lower or get off these. I understand. And like I said, these decisions are a risk-benefit ratio. There is some, I want to be clear, mixed evidence, right? That sometimes taking these, what's classically meant more for men, obviously, for erectile dysfunction, right? Viagra, Cialis, sildenafil, tadalafil. There is some evidence this can actually be helpful, not just for blood flow and helping erectile dysfunction, but there's some loose evidence that it can be helpful even just for the more abstract sense of excitement, pleasure, sex drive for men. And interestingly, even in women. I know that's a weird concept to think about, like women taking erectile dysfunction meds. So again, it's obviously not just for blood flow, but loose, want to preface, loose theoretical evidence. Maybe it can enhance extracellular dopamine in the area of the brain called the nucleus accumbens, which is associated with pleasure, and so there's some theory about that. Okay. There is mixed modest evidence of adding bupropion or Wellbutrin to your regimen in some cases. I'd say weak to modest at best, but still, if it's worth at least trying to figure out a workaround, that could be attempted if the erectile dysfunction meds don't work. Okay. I would say even weaker than the Wellbutrin evidence, buspirone or buspirone, which kind of modulates 5-HT1A receptors. I'd put that probably below the other options that I just mentioned. Okay. And then it's kind of beyond today's purview, but there are some, again, mixed, modest at best evidence of some holistic options like saffron. Okay. But those are some things that could be attempted. But again, probably worthwhile conversation regarding dose reduction and switching to alternative agents if that's viable for each individual out there. Right. I will say, sadly, for, in the realm of when you're not on these meds, right, and you're kind of off these meds and you're more in that prolonged recovery PSSD category, evidence is very mixed. And there isn't a ton of strong evidence, even for things like the sildenafil, tadalafil options. So it's a struggle because even in that category of patients, we're having not a speedy recovery, not a quick resolution, not in a scenario where they're trying to reverse it while on these meds. Like, we have very mixed evidence about that. But, I don't think it's not worth trying some of these options as short-term measures, like some of the ED meds I mentioned. Again, if side effects are tolerable, maybe it is worth trying low-dose bupropion. But again, the evidence is very weak in this realm. So there's research that needs to be done still, even in the causality, explanation, pathophysiology of PSSD, but even in the case of what agents might offer some options of speedier recovery and shortening the timelines of the prolonged recovery from PSSD. It's still a very gray, murky area. Okay. But overall, right, it is an important topic. This is an important topic. To your point, Ray, you said, I'm not anti anything. I would just like to make informed decisions. Again, in summary, right, these meds definitely do have sexual side effects when you're taking them. Pretty high incidence rate. Like I said, probably roughly around half the patients who take them get them, meaning probably the other half do not, fortunately, right? It's a wide range from abstract concepts of sex drive and desire and excitement and arousal to actual physical issues like erectile dysfunction, lubrication, ejaculation. And look, and we know it's real too, right? Because look, we have companies that are leveraging the sexual side effects to their advantage. And what do I mean by leveraging? Here's an example. I'm going to put a little graphic on the screen, right? I'm sure you guys have been inundated, especially, well, I shouldn't say just men. There's hims and hers, right? So both men and women have been inundated with these direct consumer ads, right? On social media and on TV, hims, hers, right? So here's an example for men in particular, right? They are combining Cialis, generic Cialis, which is tadalafil, mixed with Prozac. Okay. So it's ingenious, right? So they're saying here, for men who have erectile dysfunction, we're going to give you the Cialis or tadalafil. And if you are worried that you are having premature ejaculation, you're finishing too fast, and that's causing you performance anxiety and worries in the bedroom, we're also going to throw in a little bit of Prozac or fluoxetine to mix and combine with tadalafil. What's the reason? Like I said, we know that this can cause delay to ejaculation. So this has been a well-known treatment. This is not like new. It's not like hims and hers, this company, they're the ones who are revolutionary. We've had people who specialize in sexual health and even like urologists who have been treating men with SSRIs, weirdly enough, to purposely help them have longer staying power. So maybe they were not even depressed. They were not even anxious. They were not having panic attacks. They're just like, hey, doc, what can you give me to make me last longer so that I can enjoy sex longer, that my partner can get more satisfaction, that our intimacy can get better. And they'll literally prescribe you SSRIs, not for those mental health issues, but to have increased staying power. So it's been a well-known tactic for decades that's been used even by non-psychiatrists. So we just have now commercialized it to be more direct to consumer, where now they're even tossing it in, combining these things with Cialis and Viagra, right? So again, I know that that's not like hardcore proof. I'm just saying we even have these savvy entrepreneurial endeavors where they're even leveraging sexual side effects to their advantage to then promote for sexual health. It's fascinating. It's an interesting society that we live in. So again, hopefully, that helps just enhance your knowledge base. Hopefully that answered some questions to make this topic a little bit less taboo, a little bit less embarrassing to talk about. But it's an important topic to discuss with your prescriber, with your partners, etc. And again, I'm going to keep my mind open on this concept of PSSD, is in particular, not the prolonged recovery, because again, I've seen it myself. I have had patients who it's taken much longer than I would have anticipated for recovery. But I'm saying jury's still out, and but I'm still going to be open minded to this concept of permanent dysfunction. And I think that's where I deviate from some of the folks out there who are really promoting this, because I just get concerned a lot of the times. There's even a new author out there, another psychiatrist, who's like, look at me, I'm a psychiatrist and I'm so anti-psychiatry. Because I'll be blunt, it's the chic thing to do right now. But underneath it, it's what is it? It's a business decision. A lot of these folks, I'm not trying to vilify them because they have valid points, but a lot of them also have agendas, and they're very into selling themselves to do media tours, to sell books, and now their income stream is really just about being anti-psychiatry, right? So I'm skeptical of everyone. I'm skeptical of pharma. I'm skeptical of the healthcare system. I'm skeptical about academia. I'm skeptical about even the anti-psychiatry folks. I'm skeptical of everyone. I'm at the very least, I'm fairly indiscriminately skeptical. So I don't know. I don't know who to believe sometimes. But anyways, all right. For those of you, there's still several of you here. Let's just last few minutes here. I have energy for maybe the next 5-10 minutes at most. But what other questions? Q&A time. Q&A. And to Ray, I appreciate your email from earlier. It was fascinating. If you're still here, Ray, I did watch the protracted, prolonged benzodiazepine withdrawal video you showed me. Similar thing. I mean, look, I don't want to, just go off the cuff here, but like, I do believe similarly, right, that there is probably going to be a portion of patients who are going to actually have a longer recovery time from coming off of benzodiazepines than the typical, prototypical, average bell curve patient, right? And meaning that I know that was a question you posed for me via email, and I'll try to do a little bit more digging and research, do a little bit more education myself to get back to you on that one with a more informed maybe episode down the road. But because look, even with, let's say, alcohol withdrawal, right? Like the acute detox portion or the acute withdrawal period may be weeks. But trust me, I'm very familiar with the fact that some folks, even after you're through the worst of the tremulousness, vital sign changes, nausea, diarrhea, shakiness, etc., the DTs and seizures, even when you're out of that window, that can happen for weeks at a time. There are still some folks who they're going to have REM cycle disruption, sleep disruption, rampant insomnia issues, heightened anxiety that can last for even that entire following year, right? So meaning their bodies and brains have still not fully kind of recalibrated and bounced back from the consequences of, alcohol use. That why wouldn't it then be, feasible for benzodiazepines, which are essentially to your body very akin to alcohol, right? I mean, it's insane, right? Like alcohol use, benzo use, such commonly used chemicals and substances are some of the deadliest withdrawals, right? Benzodiazepine withdrawal is potentially deadly. Alcohol withdrawal is potentially deadly. Those two have the deadliest withdrawal outcomes out there, more than opioids and opiates. I'm not minimizing opioid and opiate withdrawals. Hell. It is hell. But I'm just saying, just from a lethality standpoint, purely from the withdrawal phenomenon, I'm not talking about, withdrawing from opioids and then having some unintended outcome like, vomiting and then aspirating. I'm just saying, just from the physiology of the withdrawal itself, alcohol and benzo withdrawal are the most potentially lethal withdrawals, right? So, and your body interprets the effects of benzos and alcohol very similarly. So I don't think it's a far cry to say, knowing that we know that some folks are going to have these kind of very long recovery processes coming off of alcohol, even in the midst of sobriety for 6 months, 12 months, still not fully recovered. I don't think it's a far stretch to say there are going to be some folks who are going to have this very long course of recovery / recalibration, prolonged recovery course from benzodiazepines and coming off of them. So from what you showed me, yeah, the concept itself, I don't think that's really a far stretch for me to buy into the notion, right? Um, the one thing that concerns me though, Ray, about what you showed me, and I know this is a little bit off of a tangent, is again, right? And you could appreciate this, kind of what I'm saying right now about folks who are going overboard, even colleagues of mine in the field who are going overboard with the sexual side effect permanent PSSD thing. There are people who I cringe because when I typed in and I was just searching, right, for other related videos of the topic you showed me, it just really pisses me off how many people out there are setting up these, like, I'm just going to say it, like these grifter specialty clinics out there, right? Come to my super, super specialty prolonged taper clinic. And when you really, it doesn't even take much digging. When you look at it and you research it just a little bit, they're like, for me to take you on as a patient because I'm so specialized in this prolonged benzo withdrawal phenomenon, like, you just have to cough up like a $5,000 retainer, and every visit is cash only. And we're going to do all these off label, non FDA approved things. And because of that, over the year, you're going to shell out $10,000 cash, $15,000 cash. Go, right? I mean, you probably have run across it. I'm sure you've probably better than me, right? Who have been struggling. You've seen some of these places and you've seen some of the prices. And to me, that's what I get worried about, right? When you hear some of these radical people who just run wild and they make these claims of like, I'm the special doctor, I'm the only one in the know, or me and 3 other people, we're the only ones in the know. No one else knows. We've left them in the dust. The whole field's stupid except us. There's so many of these nasty predators out there, and this is what they're doing, right? And it then almost does folks a disservice because then it almost kind of like makes other, I guess, average psychiatrists not even want to broach the topic because they're like, oh, it's just these kooky weirdo docs who are doing this, right? And it almost makes them not even interested to want to learn about maybe these topics that are going to be applicable to a portion of patients out there. So, yeah, no, I mean, look, in my 13, 14 years, I've had a few patients, right? I've had a few. I'm not going to say a lot. I'm not going to just try to, make up a story to make you feel bad. I've had a few patients where even after we did in what I considered a very cautious, slow taper of their benzodiazepines, it was still rough for them. Meaning like I'm very familiar with the concept. You've seen my videos, right, on alcohol withdrawal, benzo, detox, etc. I've had some patients where I mean, it was so dang sensitive, right? Even us going from 1.5 milligrams of Xanax or alprazolam to 1.0 milligrams was too much. That even that in itself was precipitating these reactionary withdrawal, or maybe withdrawal combined with psychological anticipatory anxiety, but the combination was just too much that like we'd have to go in these excruciatingly painful, these slow tapers sometimes where we'd have to go from like 1.5 to 1.25 to 1.0 and really drag out these things. And so at least in the handful of cases I've had, right, I mean, we've had to go very slowly in the reduction. So sometimes almost having to go back and, do kind of the tail end of the tapers very slowly. And then I hate to say it, right? Because I know it's not a sexy answer, but trying our best to support the various symptoms and almost kind of symptomatically trying to treat things that they were experiencing after they were totally off benzodiazepines, right? Meaning, they're X amount of days or months out from their last dose of benzos, and they're still having this kind of like, rampant kind of reactionary insomnia, anxiety. And we just have to just make some judgment calls on like, because some of their concerns were like, I just don't want to start this cycle again of now going back on other meds and then having to then go through serotonin withdrawal, right? With serotonin based meds, and very valid concerns. And we'd have to just kind of symptomatically treat, um, their symptoms. And I heard that doc. I'd have to do more research, but yeah, I mean, and they made some mentions of using some, like GABA related meds like gabapentin and you know Depakote and some of these seizure meds actually promote GABA as well, right? And I think that doctor's comment, I forget their name that you showed me the link of, but they made the comment that mixed results and maybe just modest benefit at best. But yeah, I mean, not trying to like restart that cycle of going back on benzos and tapering slowly and just resetting that cycle and doing it over and over again. Yeah, for some of the patients who I've had with this kind of prolonged recovery course, we have had to try to mimic maybe using other agents that could at least weekly, like very modestly in a watered down way, kind of promote GABA to some degree, and we've tried to utilize some of that again with mixed results. um and so it's not simple. It's not simple, but we typically, I hate to give you a corny cheesy answer, Ray, but like for the few cases that I've had, it's just really about getting to know your patient very well, being patient with them, non-judgmental, trying to brainstorm together without being dismissive, like what else might be contributing to these symptoms, and then case by case picking and choosing which of the symptoms in that recovery period are the most distressing, and trying to just make some judgment calls of which ones do we want to tackle with more chemicals medicinally versus finding non-medicinal interventions to also respect and appreciate that maybe they don't want to be on this merry-go-round of chemicals, right? And again, does it help to have resources and to be well off and have good insurance? Yeah, because then if you have good insurance, right, you can just get better therapists and you can get into specialty programs like intensive outpatient programs and blah blah blah, right? Versus someone who says, I got crap insurance or I got no insurance, then it becomes challenging, right? Because it's hard to throw a ton of resources at it, right? So, yeah, of course, it'd be nice if we were all multimillionaires and we could go to a luxury retreat and spend 20 grand for some specialized person who's going to pay extra special attention to me and more TLC, but that's just not reality. That's not how most Americans live. So, um, Ray says each person's brain chemistry is unique and my situation is unique to me, but I would like to get better. And I'm sure there are a small population of others who would as well. Yeah. Yeah. I hear you. I hear you. I mean, same thing, right? Even when you talk in the realm of opioids, right? It's, why is it that some people who go through opioid or opiate detox can bounce back and recover? Why are there some folks who do better off on methadone? Why are there some people who do decent on buprenorphine, right? Or Subutex or Suboxone? Why are there some people who, because of their chronic opioid use, actually get almost a hypersensitivity syndrome where now their pain receptors are so damn sensitive and pain receptors are overrepresented, right? Now they're even in more pain than they were before, right? Because of it. So that just shows you the heterogeneous nature, right? You can't do a one size fits all approach, even in the realm of opioid recovery, right? Recovery from opioids and opioid dependence. So again, right, it's not a far cry then to imagine that even in the midst of benzodiazepine recovery, why should we expect that everyone's going to have the same pathway, right? I just listed so many different things for opioids, right? Some people do the cold turkey, which I don't recommend, but some people can do the cold turkey and say, I'm never doing that again. Some people just need their other comorbidities treated better, right? Their depression, their anxiety. Some people need methadone. Some people need buprenorphine, Subutex, Suboxone. Some people, it's tough for them to ever recover and they just chronically, habitually keep using, right? I mean, so again, right? Some people are good on naltrexone injections for their maintenance. Some people need naltrexone low dose to treat their chronic pain because of that hypersensitivity pain syndrome I talked about. So, right there in like 15 seconds, I just rattle off 7 different avenues of people need to pursue, right? And no one has the same recovery pathway. So, Why is it a stretch to say that for benzodiazepine recovery, that we should expect everyone's going to have the same timeline and same pathway, right? I mean, that's what I mean by case, right? And some clinicians can be very open-minded and willing to be flexible to say we need to try something new. Others might say I've exhausted my bag of tricks, right? And they're going to refer you out to a different specialist. So it just depends. It depends. And I'm not saying that in a judgy way. I mean, look, there are certain areas I would be the first to refer people out. Like, I'm not an autism expert. You know, I'm a pretty good jack of all trades, and I'm pretty good at treatment resistant depression. I'm good at many things, but I'm also not an expert in everything, right? So that would be a lie. So I just think it really takes a good relationship between the doctor and the patient, really know your symptoms well, and be willing to have very transparent, vulnerable conversations, meaning doctors should be willing to say, hey, I'm not sure, but I've done some research, I've talked to colleagues, I've consulted with other people who are experts, and let's give X, Y, and Z a try. And are you willing to take that risk with me? Let's give it a go, right? I mean, so even that's a normal conversation to me. I tell some of my patients, I'm not sure, but I put in the extra time and effort to research a few things. And based off talking to a few colleagues who know even more than me that I trust, or things that I've read up on, I'll tell them, like, I'm not an expert. I'm kind of going into this like territory that I'm not as comfortable or familiar with. I will be that transparent with my patients. And some will say, well, that doesn't really that doesn't really make me feel super confident, and I'm not sure I want to do that. And I go, fair enough, because if I heard that on your end from a doctor of mine, I might feel the same way. Others will say, I appreciate the fact that you're willing to go out of your way to try to think outside the box, and let's go for it, right? I mean, I never recommend things to my patient that I'm like, I know this is low, super low yield, no chance of, but well, of course not, because that's the Hippocratic oath, right? It's I don't want to do any harm knowingly, right, for some useless futile endeavor. But if there's relative safety, there's some at least mixed modest evidence that it can help a cohort of folks. Sometimes you do have to take some risks in this field, as long as you're having a transparent acknowledgement of what it is you're doing, and you've been transparent with your patient, and they're really giving you informed consent, right? So that was long-winded, Ray, but yeah, but let me dive into it. It's fascinating. It's you with the link you sent me. Um, let me take a look. Let me dive into some research. Let me PubMed it a little bit more, see what I can find, and maybe I can whip together either an evergreen video or talk about it in one of these upcoming live streams. So I appreciate you, Ray. I hope you're doing all right. Um, just watch out there for predatory tactics. Okay. Sounds too good to be true. Really should be skeptical. But no, I appreciate you reaching out. I'll take a look at that stuff. As you can see, right? I mean, I tried my best. I'm not trying to give fluff. I did actually watch so that I can, respond back to you. So, but yeah, let me take a look at that. But I appreciate you guys. Thanks for those who have hung on all the way to the end. Oh, geez, we're almost at an hour and a half. See, I blab. If you guys are engaging, give me interesting topics, I could blab forever. So I appreciate you guys. But again, Tuesday and Saturday nights, 10:30 Central, 11:30 Eastern. Appreciate you. Be on the lookout. Please subscribe to my channel. I'll try to pump out a few more evergreen videos in the upcoming weeks. I've been slacking on that, but at least I've been consistent on my late night Insomniacs live stream. So I appreciate you guys. And I will check you at the next episode. Have a good night, and I really wish you guys well. Stay safe out there, guys. Catch you later.